So my topic is my topic is therapeutic approach in non-varicose upper GI bleeding, because if we would cover varicose bleeding, it would be a little bit overwhelming. See some of my disclosures. Mortality of acute ulcer bleeding is lower, but still substantial, 5.8%. The predictors for adverse outcomes are age, comorbidities, hypovolemic shock, and rebleeding. The success rate of endoscopic hemostatic therapy is currently 90%. That's quite high. That's overall. But still, if we do to have re-therapy, we will succeed in additional 75% of patients. So endoscopic therapy is the mainstay. And once patient has to go to surgery because of ulcer bleeding, the mortality rate is substantial. It's 29%. We have an endoscopic hemostatic toolbox that was basically injection therapy, mostly with diluted epinephrine, thermal coagulation, coaptive coagulation, or coagrasper, and through the scope clips. In recent 10 years, we got another armamentarium for endoscopic hemostasis, basically over the scope clips, and topic hemostatic agents. So what are the current ESGE guidelines for non-varicose upper GI bleeding? So actually in Forest 1A and 1B, bleeding, it's recommended what we all do. We do a combination of epinephrine, diluted epinephrine, injection therapy, and mostly clips, rather rarely coagulation. For F2A, we can use one of these as monotherapy. But we still have problematic ulcers, and those are the ones, the large ulcers with a central vessel and fibrotic basis. Through the scope clips, they don't grasp the vessel pretty well because it's quite hard, the basis of the fibrotic ulcer. And also in difficult positions like the posterior duodenal wall or the duodenal knee, the TTS clips application is maybe too tangential, and maybe the distance to the open clip is too narrow. So these are difficult positions to position the TTS clip. The over-the-scope clips has really revolutionized endoscopic hemostatic therapy because it has such a high compression force. The compression force, we tested it on big models, and the burst pressure is as high as a surgical suture. So there's no difference between a surgical suture and a TTS Ovesco clip. It holds better in fibrotic tissue, and the cap may allow visualization and accessibility of the bleeding vessel. So let me start this. You can see an example here, and I think everybody is familiar with it, with the over-the-scope clip. It's a cap mounted at the end of the endoscope, and the clip is mounted over the cap. And you go to the lesion. You here give this wonderful vessel. It's an F2A situation, currently not bleeding. You go to the vessel, you suck, and then you fire the clip. And then you fire the clip, and then you have a really nice compression effect. But does it translate into clinical helpful data? There was a meta-analysis first done, and it showed that the technical success rate is in 93%, clinical success rate 87.5%, 8.3% rebleeding. And you can see here, like this is an active F1A bleeding. You go there, again, fire the clip, and induce hemostasis. So this is nice pictures, nice videos to show. Therefore, in the first place, my group, we performed a second-line study. We looked at, this was the STING-1 trial, recurrent peptic ulcer bleeding. We randomized 1-to-1 to hemostasis either with standard therapy, this meant 2 clips, two TTS clips and epinephrine injection, and hemostasis with the OTSC clip. And the primary endpoint was further bleeding, secondary endpoints, mortality, surgery, and geographic embolization or other complications. So the 2 groups were well balanced. Just to see, the hemoglobin level was 7.5, 8.4. 1/3 of the patients, or 45%, were on anticoagulants, so platelet therapy. The Rockl score was balanced, and the ulcer size also balanced. So, and these were the results. We randomized 33 versus 33, and the primary success of hemostasis in the standard group was 57.6%. In the OTSC group, 93.9%. Most of these patients could be rescued with the OTSC clip, so the clinical success rate translated to an 84.8% versus 32.4%, so a highly statistically significant difference and a relative risk reduction of 73.6%. And that translated into ESG recommendation that as a second-line therapy, the OTSC clip should be used in first place. From this, so it was established now in second-line therapy. The next question was, of course, how does it perform in first-line therapy? And in first-line therapy, we have the problem that we already have a high success rate of 90%, so we have to do this in high-risk patients. But how do you define a high-risk patient? We turned to the Rockl score, and we compared standard treatment versus primary OTSC application with a power of 80%. And this was published last year in Gut. And the inclusion criteria were patients with non-variceable upper GI bleeding with a high risk of rebleeding as defined as a Rockl score equal or larger than 7 points. We did a second look endoscopy after 3 days, and the primary endpoint was clinical success as defined by successful hemostasis without evidence of recurrent rebleeding. This is the Rockl score. If somebody doesn't remember, it's about age. It's about hemodynamic stability, about comorbidities, about endoscopic features, and others. And in historical data, it was when the Rockl score was 7 or above, the rebleeding rates 43% and 27% mortality. So this was the playground we looked at. So we randomized in 9 German centers over 3.5 years. We randomized 52 versus 48 patients, either in the standard group or in the OTSC group. And the groups were well balanced again, and the results was statistically significant. The primary endpoint, no rebleeding, was 73% in the standard group and 91.7% in the OTSC group. And it was basically due to persistent bleeding. You had 6 persistent bleeders in the standard group, none in the OTSC group, and recurrent bleedings. There was only one need for surgery in this group. We had 2 late rebleedings, and we had no difference in blood units used, ICU stay, or hospital stay. So, and there was no difference concerning the side effects or risks. So special thanks to my group here in Ludwigsburg and the cooperating partners. There are now 3 other studies, also prospective randomized, comparing this in first line. This is the CURE study from Dr. Jensen from UCLA, and he had prospective randomized, but he allowed no crossover, and he had a further rebleeding rate of 28.6% in the standard group and only 4% in the OTSC group. Also here, highly statistically significant. And it was also for accumulated patient collective of high-risk patients. Dr. Lau from Hong Kong, he also did a study, an all-comers study in Hong Kong, 190 patients. The study is not fully published so far, and he also reported a significant difference on different conferences, 96 versus 86%. So, if you look at these three studies, there's a clear reduction in the rebleeding rate for high-risk patients. What a high-risk patient is still a matter of debate a little bit. The ESGE translated these results in advance in the recommendation that OTSC should be used for high-risk patients in special situations. There's another study also from Hong Kong, but not from the Lau group. They published the data just this year, last year online, this year, and it turned out not to be statistically significant, but their inclusion criteria was also only larger than 2 centimeters, but it was still 10% versus 18%, statistically not significant, but I think meaningful. And if you look at the data on an intention to treat and per protocol, once you get the OTSC in, the risk of rebleeding is substantially different between the OTSC group and the standard group. What about other methods? About these hemostatic sprays and powders? There's not so much data about it. There's basically a registry, and the registry showed overall better hemostatic rate, but the problem is that there's a quite high rebleeding rate. So these hemostatic sprays and powders are recommended only after failed compression therapy. And there's this pure stat. This is a viscous solution. It's brought on the lesion. It makes a nice three-dimensional scaffold structure. You could really look through it, and there's also only little limited data on it. So this is very interesting concerning after ESD or tumor bleedings or something like that, but the data on this is not conclusive so far. So let me conclude. I think endoscopic therapy of non-varicose upper GI bleeding is highly effective, primary and secondary. We do today early endoscopic therapy. We don't do emergent endoscopic therapy if we know that it's not varicose, and this is the point. If you're not sure about if it's varicose, then you still need to do emergent endoscopy. So, but we do it after hemodynamic resuscitation. The standard is injection therapy plus TTS clip, or injection therapy plus coagulation, still the standard, but OTSC clip has established a second-line treatment and as rescue treatment, and it's established as first-line treatment in high-risk patients, Rockler score above 7, or patients on anticoagulants, or high-risk situations. So if you have the feeling that this is a high-risk patient, you don't want to come back, you're going to put him at risk if you don't stop the bleeding immediately, then OTSC is also established in first line. Hemospray and other topical hemostatic sprays and powders are for persistent bleedings. Transarterial embolization is the third line treatment for persistent bleedings after all endoscopic modalities have been used. And surgery nowadays is only after failed embolization or if embolization is locally not available. Thank you very much for your attention.